So hello everybody. We start today with few announcements. So please keep your camera active during the seminar. So any communication that you have to do it with us, please use your McGill email. Do not use your personal email. So all the students with strong academic record, so the GPA 3.5 or higher, and are interested in pursuing a PhD, you are welcome to do their fast track exam. Supplemental financial assistance, it's available, so minimum $2,000 per person for the eligible fast track students in the academic year 2025-2026. Let me announce you the research day that it's on May 16, 2025. The abstract submission is now open. The deadline is March 17. We have a very interesting keynote speaker, and don't forget the registration link that was sent in the same time with the flyer. And we are recruiting students presenters. Please submit your idea to sisgradsurgery@mcgill.ca or to Pega. She's going to get in contact with us and you reserve your spot. Financial assistance is available from the department for all the eligible students enrolled in the thesis program. To continue receiving this support, students are required to present their project at least one time at the seminar. Thank you.
Yeah, thank you very much, Laura. So as part of our commitment to providing this well-rounded and enriching academic experience, our weekly seminar series, it brings in speakers from different fields. We have speakers from basic science. You've heard a lot of AI, simulation, and beyond. So you may wonder, why do we do this? Why do we explore such a broad spectrum of topics? So the reason is quite simple. Innovation does not happen in isolation. So it is driven by insights from different disciplines. So by exposing you to experts of these various fields, what we aim is to broaden your perspective. We want to spark new ideas. We want to encourage interdisciplinary collaboration. So that's what we want. So these skills, they are vital for the next generation of scientists and innovators. And we encourage you to actively engage with our speakers, ask questions, and you may want to consider how their work might intersect with your own research and career aspirations. So please feel free to ask. You can write in the chat. This is a dialogue. We also give awards for the for students, trainees who ask questions at the end. So today's speaker is Dr. Santiago Márquez Fosser, who is a physician and clinical informatics specialist, recognized for his expertise in facilitating data access for research at the RI-MUHC. Holding both an MD and a master's degree, he plays a pivotal role in health informatics, serving as a specialist at RI-MUHC and a consultant with the MUH Infocentre group. So dedicated to advancing healthcare through data-driven insights, Dr. Márquez Fosser specializes in streamlining access to vital hospital datasets, enabling researchers to conduct precise and impactful investigations. His expertise lie in navigating the complex processes of data retrieval, management, and utilization, ensuring compliance with regulatory and ethical standards. So at the core of his work is his proficiency with the MUHC data warehouse, a comprehensive repository of clinical and administrative data. His ability to effectively leverage his resource supports innovative research and fosters data-driven decision-making within the healthcare system. I think for some of you last year who were at the research day, you heard his wonderful talk about synthetic data. Dr. Santiago Márquez Fosser, this is all yours.
Hello, so thank you for the presentation. So now I'm going to start to share the screen. Just confirm that is fine and the audio is correct also. So can you see the presentation?
Yes.
Yes, okay. Thank you again for the invitation as last year and today. I'm very open to this kind of a presentation and share the work that we're doing. So the presentation and the name is leveraging MUHC data and synthetic data. At the end, we're going to be focusing in synthetic data because the MUHC also have a project involving synthetic data. So this is the following presentation. We're going to speak about these topics. So at the beginning, MUHC and Research Institute improvement strategy to access data for research purposes. Then an introduction to the MUHC data warehouse, what it is, what is the data inside, a description of it. Then the data warehouse from raw data to research, just to understand the flow from the different system to the data warehouse, and then to create some data extractions. Then the data warehouse structure, content summary, data dictionary, terminologies, the current Research Institute data warehouse service that the group provides, and then a description of the data access process and how to make a request. And at the end, we're going to speak about different data set types, make a description of a classification, how we understand the data sets, and a classification based on the risk to re-identify any patient. And at the end, we're going to speak about synthetic data. I'm going to just hide this. So MUHC data for research purposes, strategy focus in these topics. Basically, there are all the topics that we are, as a group, we're working. So data governance, international, Canadian, and Quebec recommendation and law, institutional policies and procedures. Then the infrastructure of, and the data architecture, useful resources, a data summary, a data dictionary, terminological directory, Research Institute data warehouse services, data access process, the tools that we use, Oracle, Microsoft, IT Rescue, Jira Service Manager, MDClone, and other platform and tools, and effective communication with the research community. So basically, we try to focus our work to improve data access, mainly in all these points. So the MUHC data warehouse introduction, what it is. So basically, it's an episodic patient-centered repository that integrates data from over 18 transactional systems within the MUHC, with less than 24 hours delay to enhance quality, performance, and research initiative. And it has been available for research since 2019. I'm gonna just describe this, what it means with episodic and patient-centered, because it's very, it's crucial to understand this. So as I mentioned, this 18 transactional system, let's say this system used at the whole network. So for example, I don't know, the ADT is a specific system being used to record the transfer of the patients. So in what bed they are, when they were transferred to another sector, and people at the organization, they use this system to track some information, administrative information. That's, for example, one system. Another system could be the laboratory. So if a patient receive a specific test, is done a specific test, they use a specific system that is also integrated and is a source for the data warehouse. So the idea is data warehouse centralized. A lot of systems try to integrate in a whole database. Why? Because if we do that, to make the extraction and to make the collection of data, first is kind of integrate all in one place. and also avoids this situation. If a researcher goes to one source system directly to extract data, maybe then they need another, and they need, for example, different sources, let's say 5. So if the researcher goes to the different 5, it's a repetitive task. So that's why the data warehouse try to integrate the data in one repository, so the extraction is only one for all those systems. So it's kind of facilitate the access to the data. And I mentioned that it's episodic. Episodic means it's a group of data points of data that have a beginning and an end. And basically, they're organized in different kind of episodes. Let's say a hospitalization, day surgery, or a pre-admission. They're the type of episode that the data is grouped all together. And it's important to know that the episode have a start and an end. It's also being used the word encounter to describe the episodic. So it's kind of a group of data. And then patient center is all the data that is collected inside of the data warehouse is always related to one specific patient. So the patient is the one that centralizes, if you want the information. All the information of that patient is going to be linked to one patient. Then the data about the facts that are recorded. So this is data from 2024. So it's 4.9 million patients. It is more of the population of Montreal because we have historical data and we have a historical data for many years. That's why the population is so high. And then 28 million of different episodes, more than 400 tables, more than 6,000 tables columns, and more than 7.5 billion facts. So the amount of data is quite big. So that's why it's important to centralize the retrieval of the information. This is a list of the sources. So archives, emergency medicine, OPERA, this operation room, outpatients, imagine, and in parentheses the name of the software of the system being used. So lab, for example, is Cerner, pharmacy, BDM, cancer tumor registry, that now it was changed to Sardo. There is another tumor registry, metric and Sardo, infection control, nosocols, blood bank, and accident and incidents. So all these systems kind of integrate in one repository. About the structure, so in the center is the thing that I described, is patient center and episodic. And they are linked, all the information is linked with an episode of care at the emergency. For example, episode is pre-admit, inpatient, day surgery, emergency, outpatient, radio-oncology. That's the kind of episode that, again, have a start and an end of the episode. So it's kind of a grouper of all the information that happened at that in the patient in that kind of episode. MUHC side, MCA, Royal Victoria, the Neuro, the Children's, Lachine, all the different hospitals, they are using the source system integrated in the data warehouse. Have established process for research, data access, and a full-time analyst with research experience and method for creating data sets. This is a center, basically it's an episode, when they start, when they end, and information about the episode. In these slides, we're seeing from the source system to the end, the result of why we're using the data. So from the source system, we have different source systems, and we have kind of different way to integrate the data. So basically, it's a ETL process. ETL came from extraction, transformation, and load. So basically, the raw data is taken and then transformed and then loaded in a kind of organized way. So we call that ETL process. And it could be done by operational data store, like directly extraction and deposit into different tables, or with an interface HL7 engine is kind of a software that processes messages. Let's say, for example, lab, they use it. So when a lab is done, an HL7 message is created to inform the result. So those messages are captured and stored in the data warehouse. It's kind of the two ways it's taken the information. And then the data warehouse, basically we have two enterprise data warehouse, and then a kind of a copy that is an anonymized data warehouse. That is the two main repositories. And this is the way to extract the data. So we have basically two, and there's a third one coming in. So we have basically kind of software to make the extraction of the data. So basically it's a software using SQL to write some code and make some extraction of the data. With the extraction, they create tables, and with the tables, a file. And also it was done Cohort Explorer. Let's say dashboard, they are direct connected to the database. So there's a visualization tools. The complexity with the SQL is that you need to know how to use SQL to make the extraction, and you need people every time doing an extraction for someone else processing the request. And the Cohort Explorer is easy because it's, let's say, if it's connected, it's easy to see the data, but it needs to be built. So it needs to be built accordingly with the needs of the user or with the needs of the, let's say, if it's for surgery, and the Cohort Explorer is going to show episode for surgery, it needs to be built every time or for each user. And then we have another tool that is going to be integrated, that is MD-Clone. The MD-Clone is kind of I would say a mix between both, because in a way, in an easy way, you can create some kind of SQL query, but in a very usable way. So it have a process, and then I'm gonna explain a bit more about this. But kind of it's a mix between both. It's an easy way to make a query, and it's an easy way to explore the data. And then the use of the data could be for performance, for quality improvement, or for research. Basically, this is the three main purpose of the use of the data. I'm going to speak about terminology. So a terminology or a vocabulary basically is a medical terminology. Vocabulary are terms to record patient findings, circumstance, events, or interventions with sufficient detail to support clinical care, decision support, outcome research, and quality. And here I put the main domains using terminologies, and the terminology that we are using here, the MUHC, and I just put here a standard, just an example of a standard terminology. So for example, the domain is diagnostics, and the MUHC terminology, we use ACD9 and ACD10. And it's the Canadian version of the ACD10. And we switched a few years ago between ACD9 and ACD10. So for historical data, we may see ACD9. For new data, we may see ACD10. But both are recorded at the data warehouse. And then this is an example of the standard. So ACD10 is a standard, it's an international standard. Stomach CT is another standard recognized internationally, and this is just an example. And then for procedures, maybe it's accurate to say here if there's people from surgery. So the CCI is here I put it down, it's a Canadian classification of health intervention. It's being used at the MUHC, and is a standard and is recognized here in Canada. So this is a way to store the different procedures. And each of them, just to mention each terminology, they have their own code. They have a code, let's say a number, normally it's a number, or a mix between letters and number, and then a description or a detailed description. Normally it's like that. And then it's important to know that in the terminology they have it's like a tree. So the big branch of the term is more general, and then if you go deep inside of the terminology, you search for more detail or more specificity in the description of whatever we want to store. And then for drugs, we use AHFS. that is an American Hospital Pharmacy Service. It's a classification for drugs. Normally, it's very general and not so specific. And we also use DINS, drug identifying number, that is recognized here in Canada, and is way more specific and granular data. And here, as an example, I put RX norm. There is another classification for drugs. For labs, we use at the OptiLab, they are using local terminology, and there is linked also to the terminology of the ministry. And for example, a recognized standard is LOINC. The idea is into the future going to this direction, going to LOINC. And then for images, we use DICOM. It's a very recognized standard. Most of all the system using images, they use DICOM, and we also use DICOM at MUHC, and it's also recognized as a standard. So basically, it's a screen of the whole terminology, or the biggest one being used at the data warehouse. I put this graph. This is a theoretical graph. Okay, it's not the data is not organized like this, but I put it as an example of how to understand healthcare events or healthcare services, and it's kind of a connection between I would say the business model, like the healthcare service provided, and also the database structure. But it's more theoretical. It's how to understand any data set we can understand like this. So let's say a healthcare event, and it could be whatever. It could be a lab, it could be a procedure, it could be a hospitalization. And this is all the information linked. Probably there's more information, but it's kind of to understand the concept of the healthcare event. So let's say there is a healthcare event, is made to someone, so to a patient. So it's to whom is being done this service. So we have the directory table of individuals, how to store all the information for the patients. And then it's by whom. Someone is providing the service. So it's the directory table of providers. So it could be inside of this table of providers, we can see the profession, the specialty, the duties, the function, department, division, and all the information inside of the provider, I would say, a role. So there's two kind of role, one that is receiving the service and the other one that is providing the service. And then we have where is this service or this healthcare event happen. So it's the directory table of physical places. So this could be from the hospital, let's say Royal Victoria, the whole hospital, to a specific bed. So these physical places, they need to be stored as a directory. So we have a place where we store all the physical places. And who finance or who pay, directory table of sponsor finance. And then we have, I don't know if you see here, yes, centralized terminology control, all the information that uses this terminology that I just mentioned before. So what is used? So we have the directory table of inventory. So this is, it could store information from something being used in a procedure, like in a surgery, or as a drug, or something given to the patient, like anything that is being used in the service. And then what is done, that is the directory tables of services, like for example, CCIs and procedures and something that is being done to the patient, and what for. So we have directory table of conditions. So for example, condition, it could be a diagnosis or another condition that is not a diagnosis. But it's this, if we have to understand any data set happening in the hospital, like any database or any group of data, I will use this structure to conceptually understand the data, and also to check if I'm forgetting something. I'm gonna just pass. Something now. So research into data warehouse service. So useful resources, we create a data summary for research. It's a list of variables organized by source system, and we have a version that it was done in 2023 and it was approved in 2024. So you have a few months already. Basically, it's a document describing all the data inside of the data warehouse. Basically, it's a summary. It's a 4-5 pages document to describe the data inside, mostly for data scientists or people directly involved with the data. Here I put some examples of the content summary. So we have patient identifiers and demographics. So for example, unique patient ID, first name, last name, father's name, and different information that collects information for the patient directly, like demographics. We have episode identification. It's a kind of information directly related to the episode type, or the start date, or the duration, the length of stay, episode patient age. That is, sometimes we have information that is kind of freezing at that moment of the episode. So for example, the age that the patient had when he was at the hospital at that episode. An example of another source is ADT, so it's information about the discharge, transfer, and admission of the patient, and some information collected there. This is another source that is Medeco. So basically, when a patient leaves the hospital, a group of people they review the discharge and they code the episode, and they tag with this different information. So for example, intervention, principal intervention, secondary intervention, CCI code, and they revise this. Diagnosis, principal or secondary diagnosis, DRGs, severity, mortality, services, physician, specialty, day, duration, consultation, domain, physician, and date. And this is just a main description of medical source, but it is more detailed. And this is another, for example, source. This is, let's say we're speaking about drug information. So conceptually, medically, we understand the cycle of the medication following this. No? So we have in the drug information, we have first the prescription, then we have a transcription or validation. Sometimes we don't have this step, transcription or validation. Maybe the prescription goes directly to the dispensation without a transcription. Transcription means someone read the prescription and they put it in a system. Sometimes we don't have this. It's directly prescription to dispensation. Then the administration, and then the monitoring. So basically, this is the circle that we understand conceptually the drug management at the hospital, and only the medical part. No, the pharmacy, they use kind of another circle, but the medical part is kind of this one. And at the data warehouse, we organize the same. So drug prescription, information about the prescription, drug dispensation, information about the dispensation. At the data warehouse, we don't have the administration part, and we don't have the dispensation happening outside of the hospital. So if a pharmacy outside of the hospital is doing the dispensation, that information is not being collected at the hospital. So this is another tool and useful resources. Sorry, I didn't mention, but this document that I described is available at the Research Institute portal. So if you have an account there, you just can download this document that I just mentioned. And there's another useful resource. There is a data dictionary app that intends to be a more detailed description of the data collected at the data warehouse. And I didn't mention this, but a purpose to create these resources is to fill the gap of knowledge of the people requesting the data. So there's a lot of people that maybe they don't know what is inside, and they have an idea to make a research, but they don't know if the data is available. So it's kind of a problem in the communication, because sometimes maybe they send an email, or they start the research and they don't know if it's feasible. So this is a way to try to evaluate the feasibility of the study before starting. So this is a dictionary app. So basically we show source system, field name, field description, English, French, field type for research. If it's more clear, this is a and more database management, and this is a kind of a more understandable way. Sites where this is collected, start year, end year, and if it's a direct identifier, yes and no. So just to recap, so each line is kind of a column in the database. So it's let's say this one, vital signs, no, signo vital douleur. So it's kind of, if the patient have pain, yes or no, it's just very specific, it's a data point. So it's a description of all the data points. And if you click in each row, you're gonna see more data about this value. So for example, possible values, number of total values, number of distinct values, different information of that variable. But it's always aggregate numbers, and it's not confidential, because yes, it's confidential, but it's not. You cannot identify no one just knowing this. And the data dictionary app basically is filtered by a domain, source, field type, sites, direct identifiers, start date, and end date. So, and also have a search field, so you can search for any specific data that you want. So it's kind of, we have some filters to display this dictionary. I'm gonna just open it here so you can see it. Actually, it's here. So we have this table that is around 2,237 rows. It's a big one, I would say. And here in the left is a way to organize and filter the database. So it's a way to show how is this main structure and the data content. I came back here. Sorry. So the Research Institute Data Warehouse services is kind of the service that the groups provide. So first is a consultation, and to request this, you have to go to the Research Institute portal, and you can open an AT Rescue now and to open a consultation. So basically, it's to evaluate project feasibility, if the project if the database have enough patients, if the variables are available, help preparing data specifications. And also for the data extraction, we organize the type of data based on if they are aggregates, anonymized, de-identified, or identified information. And we also have some office hours every Tuesday, 11 a.m. is at the core, and also online. There's a link. And after the presentation, I'm gonna give this presentation so you have the links also. So basically, this is the two main services that the group provides. So one is a consultation. So we recommend being the first before doing the data request, make a consultation to evaluate feasibility and ensure that the patient is that the data is available. So the different data could be aggregates, anonymized data, de-identified information, or identified information. To start a request, we are missing this step, that is the Nagano submission. So basically, we recommend doing the consultation before the Nagano submission, and after the Nagano submission and all the paper and the project is approved, do the data request. So the data request came after the Nagano and the authorization to start the research is done. So the data request, based on the data set that the researcher is asking, is the documentation that we verify that is correct. So for example, for the aggregates, actually for all of them, the researcher, they have to do a request specification. Fill what is the data that they need for the project. And a data user agreement. Basically, that's for all the type of information. And then for the anonymized and the rest, not the aggregates, for the aggregates could be done without the approval. But for the rest of the data set, they need approval protocol, the REV approval letter, an authorization letter, and if they have a renewal of the REV, authorization, and also if they have an EFBP approved, they have to submit it. Basically, the EFBP is a documentation needed for the for NAGA, for approving a protocol. How to do a request? So basically, if you go to the Research Institute portal, Research Data Warehouse Service, and you can AT Rescue, and you can create a consultation or a data request. And the idea is in the following months, we're going to make an update in this software, the AT Rescue, to request the data, and we're changing to another software. So it's going to kind of be different, the system, but for the moment is a way to request a consultation or a data set. So this is a different type of data. So we divided into 4. I'm going to just explain these 4. So aggregates is an integration of information concerning many individuals. So let's say how many patients they have diabetes in 2023. So it's just a number. Let's say it's 5,000. So just with the number, you cannot identify someone. So that's considered an aggregate information and cannot track back to a specific individual. Anonymized, direct identifiers are removed, no code allowing subsequent re-identification is retained, and the risk of re-identification of the person from the remaining indirect identifiers is very low or low. De-identification is information whose direct identifiers have been removed and replaced by a code. It is possible to re-identify specific patients if have access to this code. And then identifier information, direct identifiers basically are there, or the indirect identifiers are in a big amount that it could be considered as a direct identifiers. Another concept to understand is the data linkage. So sometimes the researcher, they have to merge data between different data sets. And to merge data, it needs to be done by specific direct identifiers. It could not be done without that. So it depends who does the data linkage is the risk of re-identify someone. So for example, if it needs to be done a data linkage between the data warehouse data and another source outside of the hospital, so if it's done by the researcher, they have to request the identifiers. Or if it's done by the data warehouse group, without the researcher having access to the data, it could be done in a secure way too. It's important to know that sometimes the project, they need this data linkage. And then we talk about all the process and all the MUHC data warehouse. I'm going to speak about synthetic data. So basically, synthetic data is, as mentioned here, is a kind of type of data. So as a definition, synthetic data is a non-reversible artificial created data replicating real-world data, statistical characteristic, and correlation. So basically, it's kind of a copy of the raw data, and each data point are modified to keep the statistical characteristic of the data sets. But it's good to understand that it's not the same that real. We cannot consider as a real data. It's kind of a replica of a copy. And using discrete and non-discrete variables of interest. Let's say synthetic data does not contain identified information because it uses a statistical approach to create a brand new data set. And here's a distinction between the anonymized data and the synthetic that, based on the literature, we can say the synthetic data is more secure than anonymized, but it's arguable, I would say. This is a graph that I like to present and to view with you. So basically, it's a balance between privacy protection and data utility. So the different data sets that I mentioned, let's say that is identified information. The data utility is very high. but the privacy protection is very low. So people are using direct identifiers. If it's coded, the data utility decreases, and the privacy protection it increases because it's de-identified. Actually, de-identified and coded, and this is only de-identified, anonymized information, and aggregates. And the idea with synthetic data is kind of being here, where the utility of the data is bigger, and the privacy is also bigger. So the idea is to be centered here in the right top corner. So some benefits and some limitation of synthetic data. So benefits: retrospective research studies explore data independent of the rep, like the process. Normally, people they don't need to submit a protocol to the rep to use the synthetic data. Access that data at the moment and also explore the data dynamically. So I can create a data set, and if I don't like it, I can modify the query and recreate another one. Maintain patient privacy, share the data worldwide. Ideal for artificial intelligence testing is something that it could be used. Some limitation, not useful for prospective studies. A minimum of 200 patient population. This is a limitation that is understandable. If we create a population of, let's say, 5-6 patients, it's going to be easy to recognize, maybe, so that they have a minimum of population of 200 patients. Some information is not available using synthetic data. For example, images. Theoretically, it could create an image, but they are not normally shared. Categorical variables are censored in a high percentage, and the more specific, the more censored. And multiple repetitive events are not available. Free text and other variables could be found in local languages also. Okay. So this is an example of an image. This is information of an image. So the synthetic data, basically they change each point, but the whole idea is to keep the same like overall image correctly. And this is kind of the idea of the synthetic data. Another example, original data, they have this population, mean, age, weight, different information. It's most common pants color blue. And if we create a synthetic data, we keep similar statistical properties, but it's not exactly the same data set. This may be too specific, but I put here a link to an article. They explain how to securely create a framework to go from the original data to a safe synthetic data. If someone have the interest to replicate the generation of synthetic data, they can follow this link, and it's a kind of a recommendation of what to follow to create synthetic data sets. This is some open source options. I just put it here. I'm not gonna go to describe each of them, but I put it in here in the presentation. Some other options, for example, a data anonymization tool, and some available in the web sources of different synthetic hospital data sets. Something about the MD clone. So, sorry, about the different private companies that provide synthetic data, and MD clone, that is a link also with the hospital and with the university. They have a contract. So the idea is to put MD clone link directly to the data warehouse and start creating synthetic data of the MUHC. This is another hospital database available. So around 2 years ago, the CLIP and the Department of Surgery and the McGill University, they signed an agreement to use MD clone to use synthetic data from Shiva's hospital. We still provide this kind of access. So if you are interested in obtaining this kind of data, you can send me an email. But just to let you know that this is information from Shiva's hospital, not MUHC. but this is also available. At the MUHC, so basically now they are making this connection with the data warehouse to this software, so user can access the data. At the moment, it's a step-by-step, and it's different domains of data being integrated. And for example, condition and encounters and also demographics are already linked, and with a group of tester and first users having access. And the idea is in the following months, probably for the summer, it's going to be open for research purposes. And basically, in the software, just a description. So you have a wizard. There's a mandatory step to follow, and it's a reference event. You set the reference event that you want, additional inclusion, time-related events, demographics, finalized cohort. At the end, you have a button saying generate synthetic data. So it goes going to download directly a file. The idea of this presentation is not to make a description of all the software, but just have an overall view of what it is. And then just to finalize, we have a virtual office hours every Tuesday at 11 to 12. So if you want to ask any question or something, we are there. It's going to be until January 28th. Sorry, until February 25. And then we're going to add more. But every Tuesday at 11 at the core, we have some office hours that's open to the community to come and work together. And then thank you very much for the time, and I hope that you have a question or comment. And just before finishing, I just want to mention, because I'm a health informatician and I really like informatics stuff at the hospital and the merge between both. I just want to show you this. This is a game that was created with an ex-colleague in Buenos Aires. They create a game that is it's an immersive game for kids undergoing a surgery. So it's if you want to explore this and to download this game, just or if you want more information about this, please let me know. As I'm gonna show you here, it's just a game that was created by physicians. It's kind of exploring and in an immersive way a kid going to the hospital and playing something. I want to mention this if we have some people related to surgery and they want to explore this. Just let me know about this if you want. But just thank you very much.
So thank you very much for that wonderful presentation. Any questions? Anybody? So does the synthetic data platform, does it support with longitudinal patient data synthesis, so that you have a patient maintaining realistic patient trajectories over time? Do you have that kind of data?
Sorry, you mean if you can study the trajectory of a patient? Yes. Yes, because in the data set that you can create, you just select what data points do you want in the whole trajectory. So okay. Yes, you could generate that, but it's going to be more accurate as much information is connected to the software, just that. So if you have lack of information that is linked, you will not be able to generate a lot of data points in the trajectory of the patient. So it's going to be directly related to the information that you put in.
So how does your system handle if you have high dimensional clinical data? For example, you have genomic information, for example. How does it handle? I know you talked about
at the MUHC, I will say that genomic information, if integrated, is going to be one of the, not at the beginning, I would imagine, being integrated this kind of information. And because genetic, I will split it in two. So one is genetic data related to the test, just when was done, and information what kind of test was done, and the main result. That probably is going to be integrated first. But then if we're speaking about genomic data with a huge amount of data, I think those kind of data, they are not going to be linked initially. It's not something that the data warehouse has directly the information. This second part, the first part related to the test, like result and what kind of test, when was done, yes, that's way more easy to incorporate. And the system that I saw at the Shiva, they don't provide genetic, this kind of very specific genetic data. And also it will be very hard to understand how they manage the synthetic part of that. Because I don't think that is a numerical thing. So they cannot make statistical equivalence with genetic data. So I think that is more like a categorical result. So it's going to be high sensor to create those synthetic. That's my thinking.
Yeah. So you explained really wonderfully the synthetic data generation process. So how does it address things like selection bias and missing data?
So the system is not filling the missing data.
Okay.
So missing data, if the database is not connected to the software and they have, let's say, 0.5% of missing data, they're just going to display this value have 55% missing data. But it is not a tool to fill the missing data. They will not fill it. It's not a synthetic generation of missing data. It's kind of a replacing of the actual data that is not missing with all the data to generate a synthetic data set. But the missing data is not gonna be solved, because the idea is to be more transparent with the data inside. So if they start to fill the missing or the missing data, it's kind of they may put some garbage in the data set that you want to retrieve, you want to extract. So the idea is being more transparent with the data inside.
Thank you. There's a question in the chat by Cassandra. Says, when you request data from the warehouse, what format is it provided?
Format is a CSV files. If it's a big data set, it could be several CSV files. And also the MD-Clone platform is providing data as CSV files. So at the end of all the query using MD-Clone or making the extraction through SQL and like I would say the normal process is a CSV file.
Okay. Now, when you showed the original data and you compared it with the synthetic data, the difference was not much.
Correct. The idea is to be as similar as possible.
Right. So it cannot be reverse engineered. That's what you meant. It can't be reverse engineered.
I would say no with an if, just that. Because let's say MD-Clone is working, they don't provide you with the algorithm to create a synthetic data set. So no one here at the hospital, we don't know where is the algorithm being used. And I think it's good to don't know that, because it's kind of a secure way to avoid the reverse engineer to the real one. So basically, if we will know how they create the synthetic data, we may apply some reverse engineer to get the original. But because that part is missing, it's very hard to go back to the original.
Okay. Any more questions?
Yeah,
Mike?
just a quick question. Yeah, and a wonderful talk. Very informative. I really liked it. I was just wondering, what is on a practicality note? So, what would be the lead time if we put in an application for data, and is there a cost to it?
So I was split it in two. In the MD clone, if you want synthetic data and you have access to the platform, is like at the moment. You can just build the query as you want, extract, and play with the synthetic data at the moment. If you had to make an extraction of data or request of data to our group, I was split in two. If you need aggregates data, so let's say how many patient X, you can do that now. Saying I'm a PI and I need this kind of information to evaluate, I don't know, how many patients with a rare disease do we have. So let's say evaluate feasibility. That you can do it any moment. And I would say it's quite fast to make those extractions because we don't need to check the requirements. It is easy.
Sure.
And then if we make a request, it's going to depend the amount of data that you request and the level of complexity and the hours needed to do the job. And it's not only the hours someone working on that, it's also the hours verifying that everything is fine, all the documentation, and also is the communication between the researcher and the team. Because sometimes they have a question, okay, this document is not ready, or something is not very clear, and they start a communication with the researcher. And normally, it takes a few months to process the request. The whole idea is to put down this time into 1 month. That's the idea. But we are far for that objective, just that.
So if we had a grant that's due like April 1st, we probably have to wait till the next round if we wanted some data.
It needs to be done to April 1st or submitted?
Well, yeah, I think the final submission is April, yeah.
Okay.
Fair enough. Oh, and the cost, is there cost?
Because
The cost
the
for that.
submission is soon.
Yeah. Yeah, no, understood. So you obviously have to prepare in advance. And the cost, is there any really cost in
At the moment, there's no cost. It's
Okay.
covered by the IT of the Research Institute and the MUHC at the moment, data warehouse. And we may start to charge in the future. But first, it's an optimization of the process, and then we may start to charge.
Fair enough. Perfect. Thank you.
No, thanks to you. And I'm open to any question. If you want to send anyone an email or plan a meeting to evaluate the feasibility, we do those kind of things. Just let me know.
Yep. Thanks.
I think Mike was asking really interesting questions. So we've never used synthetic data, they say. How do journals and grant writing agencies, how do they view synthetic data?
So I will say depend of for what. So if you are planning a whole research project, I will use the synthetic data to evaluate or to make a pilot or to make a feasibility, but not to obtain the main results of the study. So to evaluate feasibility and to plan the research, I think is very, very good. But to submit a whole project saying we're going to use synthetic data is kind of unnecessary, because first, you don't need review approval to use completely synthetic data, but you may need the review approval if you want to obtain the real data.
Right. Any other questions? So if there are no more questions, thank you very much for that wonderful presentation. Really appreciate it.
Thanks to you. Have everyone a nice day.
You too. Thank you very much.
Thank you.